Who is protecting our mothers? A call for medical justice in South Sudan. What is happening to our mothers? What is happening to our daughters? What is happening inside our maternity wards? Today I speak not with rumors, not with hatred, but with deep concern. Across Juba and other parts of South Sudan, families are telling the same story. Pregnant women, many around 30 or 31 weeks, walk into a clinic feeling normal. Within minutes, they are told, "Your blood pressure is high. The baby has no fluid. You must operate immediately. If you delay, the baby will die." Fear enters the room, and once fear enters, reason disappears. Then comes the next sentence: "Bring dollars, upfront, before discussion, before second opinion, before full explanation." How did childbirth become a financial emergency? How did pregnancy become a surgical routine? How can almost every expectant mother suddenly become high risk? Are we witnessing a genuine epidemic of severe disease? Or are we witnessing a system that has turned surgery into income? Let us be clear. A Caesarean section is a life-saving procedure when medically necessary. It is not evil. It is not wrong. It saves women from obstructed labor. It saves babies in distress. It prevents fatal complications in true emergencies. But surgery is major intervention. It carries risk, infection, hemorrhage, anesthesia complications, future uterine rupture, infertility complications. In a fragile health system with limited blood banks and inconsistent post-operative monitoring, unnecessary surgery can be deadly. The global medical community, including the World Health Organization, recognizes that Caesarean sections should be performed when medically indicated. Research consistently shows that excessively high C-section rates do not automatically improve survival. When surgery becomes the default rather than the exception, alarm bells should ring. Now, let us address the issue at the center of many of these cases: high blood pressure in pregnancy. Hypertensive disorders such as gestational hypertension, preeclampsia, and eclampsia are serious. They are real. They can kill. Severe blood pressure, typically readings of 160/110 or higher, is considered a medical emergency. Uncontrolled severe hypertension increases the risk of stroke, seizures, organ failure, and maternal death. WHO and international obstetric guidelines are clear on this. Severe preeclampsia and eclampsia require urgent hospital management. Magnesium sulfate is the recommended medication to prevent seizures. Blood pressure must be controlled using appropriate antihypertensive medicines. Continuous monitoring is essential. And here is a crucial point. Delivery is the definitive treatment for preeclampsia. The only cure is ending the pregnancy. But ending the pregnancy does not automatically mean performing a C-section. Mode of delivery depends on the condition of the mother, the baby, the gestational age, and whether labor can be safely induced. In many cases, especially when the mother is stable and the baby is stable, induction of labor or assisted vaginal delivery may be appropriate. For pregnancies beyond 34 weeks with severe features, many guidelines recommend delivery after stabilization. Before 34 weeks, decisions are more complex. Expectant management may be considered in carefully monitored settings with adequate resources if both mother and baby are stable. But here is the key. These decisions must be evidence-based. They must be documented. They must be explained. They must not be driven by fear or profit. So we must ask difficult questions. Are blood pressure readings being measured correctly? Are repeated readings being taken? Are appropriate cuffs being used? Are anxiety and temporary spikes being mistaken for severe disease? If almost every pregnant woman is being told she has high blood pressure, then either we are facing a national public health crisis or diagnostic standards are being misused. And what about the frequent claim that the baby has no fluid? Amniotic fluid levels can be measured by ultrasound. They are not guesses. They are quantifiable. Are these measurements documented? Are patients given copies? Are machines calibrated? Are staff trained? Are second opinions possible? In medicine, diagnosis must be measurable. It must be recorded. It must withstand review. Without documentation, diagnosis becomes power, and power without accountability becomes abuse. Families report being psychologically pressured. If you love your wife, you will agree now. If you refuse, she may die. Sign here. This is not informed consent. This is coercion. Consent requires explanation of risks, alternatives, and evidence. Consent requires time when possible. Consent requires freedom from intimidation. When money becomes urgent before medical clarity, trust collapses. And trust is everything in healthcare. Let us consider the consequences. If unnecessary C-sections increase, infections increase. If unnecessary preterm deliveries increase, neonatal deaths increase. If families are forced to pay large sums in dollars, poverty deepens. If maternal deaths rise, the nation bleeds silently. And when women lose trust in hospitals, they avoid care altogether. They deliver at home. They delay seeking help. Complications worsen. A healthcare system can collapse not only from lack of equipment, but from lack of integrity. Now, let us speak directly to government and medical authorities. If the number of hypertensive diagnoses and emergency deliveries is truly high in South Sudan, this is not gossip. It is a public health emergency. It requires data. It requires investigation. Responsible government action must include mandatory national protocols aligned with WHO standards, ensuring magnesium sulfate and antihypertensive medicines are consistently available, training all staff on accurate blood pressure measurement and diagnosis of preeclampsia, publishing facility-level Caesarean section rates, auditing indications for surgery, conducting independent maternal death reviews, standardizing fees and banning coercive upfront dollar demands in emergencies, protecting whistleblowers within the health sector. If one hospital performs surgery on the majority of its patients, that hospital must justify its practice with documented evidence. If maternal deaths are high, case reviews must identify exactly what went wrong and what will change. Transparency is not optional. It is the foundation of trust. To ethical doctors and nurses, this is your profession. It is sacred. The principle, first, do no harm, is not symbolic. If malpractice is occurring around you, silence will not protect your reputation. Accountability will. To families, ask for repeated blood pressure readings, ask for written results, ask for ultrasound reports, ask whether induction is possible, ask for second opinions when time allows. Emergencies are real. Severe preeclampsia is real. Eclampsia kills, but emergency must be proven, not declared without evidence. And to those who may be abusing the system, remember that short-term profit cannot erase long-term damage. A society that begins to fear its maternity wards is a society in crisis. South Sudan has suffered war. We have suffered displacement. We have suffered corruption. We cannot afford corruption in maternity care. If we destroy the safety of motherhood, we destroy the future of the nation. This is not a call for anger. It is a call for reform. It is not a call for blame without evidence. It is a call for evidence. It is not a call for violence. It is a call for transparency, because every mother matters, every child matters, and protecting the womb is protecting the nation. The question remains, who is protecting our mothers? And if the answer is unclear, then it is time to demand clarity now.